Hi, everyone. I'm Dr. Manju George, the Scientific Director at COLONTOWN. Today, we have with us Dr. Michael Lee. He's an assistant professor at MD Anderson, and he finished his MD at from Duke University, and he's board certified in internal medicine, hematology, and oncology. Dr. Lee, I'm really excited and happy to have you here with us. Please take it away.
Thank you very much. Can I just confirm you're seeing my slides in slide screen view?
Yes, I think, yeah, yes.
There we go. All right. So I'm very pleased to be here. Thank you so much for inviting me to talk about this exciting new study that we and many other centers are getting underway, looking at novel targeted therapy combinations, particularly focused on this new class of drugs called ERK inhibitors in certain molecularly defined subclasses of colorectal cancer. This is the HERKULES-3 study. So just as a way of background, cancer cells in general, or cells in general, are very finely tuned regarding when they proliferate and multiply. Typically, when a cell multiplies, it only does so in response to when kind of the environment is right. And usually in that situation, there will be molecules called growth factors released around the cells, and these bind to receptors on the surface of the cell. In particular, in colorectal cancer, something called the epidermal growth factor receptor, or EGFR, is a very important growth factor. Now, typically, when this binding occurs, this triggers kind of a cascade of proteins being activated into an active state and kind of propagating the signal through, one protein through another, until it eventually leads to a number of cellular changes that actually cause the cell to multiply. You can think of these intermediate steps as a series of molecular switches. In particular, this MAP kinase pathway, so to speak, which is downstream of this EGFR receptor, is a very important kind of modulator of cell multiplication. Normally, this process is very tightly regulated, as I said, in a normal cell. However, in the process of colorectal cancers going from a normal colon cell to a cancerous cell, typically these cells acquire abnormal activating mutations in one of these molecular switches. And we know that significant proportions of patients with colorectal cancer actually have activating mutations in one of these key genes that eventually leads to this kind of pro-growth switch being turned on all the time inappropriately. So we know about 45 to 50% of patients have a mutation in a gene called KRAS or NRAS, which causes constant activation of these growth pathways. Another 5 to 10% of patients have an activating mutation in a gene called BRAF, with the particular mutation in BRAF called the V600E mutation, most common among the BRAF mutations. These are very clearly driver mutations driving the biology of these cancers. And while we're starting to develop new therapies kind of targeting these very clear potential vulnerabilities of these cells, we need more novel, more effective therapies for these ranges of mutations. Clearly the cells are being driven by abnormal signaling through these kind of constantly turned on genes. And, if we can find more effective ways to switch off these genes or kind of block the downstream signaling that is a consequence, then this is a potentially very powerful strategy. ERK is one of the key downstream kind of effectors downstream of activated RAS or BRAF. ERK is one of the last kind of switches that then goes on to directly activate a number of these kind of transcription factors that cause the cell to go on to multiply, and so on and so forth. So it's one of the last common nodes in this pathway that we could target. And kind of because it's further downstream, there's a lot of preclinical kind of laboratory data showing that targeting ERK may be a particularly potent strategy, even more so than targeting some of these upstream components. And in fact, while there are not currently ERK inhibitors that are FDA approved, there are several novel ERK inhibitors that are being developed. And one that's particularly exciting is being studied in the HERKULES-3 study. This is the ERAS-007 compound. This is an oral, pill-based treatment that's selective inhibiting ERK, and it's been active in the laboratory. So without going into too many nitty-gritties, actually, Shown here are on the left-hand panel are a number of mouse models of KRAS or BRAF mutated colorectal or pancreatic or other cancers. And you can see here the red line on the bottom actually shows the activity of the ERK inhibitor, which was previously called a different name. And you can see that kind of when you looked at it compared to other kind of earlier ERK inhibitors or other classes of drugs targeting upstream, like at MEK or BRAF, that the ERK inhibitor, at least as a single agent for a limited period of time in these mouse models, seemed to have the most promising level of activity. On the right here, you can see specifically in a range of colorectal cancers that the ERK inhibitor was active in the majority of the mouse models that were studied. And in particular here, the shaded kind of maroon or blue bars show KRAS or BRAF mutated mouse models where you can particularly see benefit. Now, with all that being said, as much as we've studied single agent ERK inhibitors and, the early phase studies look at single agent drugs, we know that, from long experience with kind of inhibitors of this pathway, that you have better activity for a longer duration of time if you target in combinations of therapies. Without going into too much detail, generally in the past, when you've tried targeting this pathway with a single agent, for example, MEK inhibitors or BRAF inhibitors, there's been a lot of kind of adaptation within the cancer cell that kind of reactivates upstream signaling, and it can kind of bypass the level of drug inhibition. As a consequence, we've learned that and studies in the lab have also shown that we have better outcomes if you treat with combinations of therapies. We really think the best chance of having more activity that's clinically significant for our patients is using combinations of ERK inhibitors with other rationally targeted drugs. So one combination that's being studied in the HERKULES-3 study in KRAS and NRAS mutated patients, which again are about 45 to 50% of colorectal cancers, is combining this ERK inhibitor with a compound of drugs called the cyclin-dependent kinase 4/6 inhibitor, CDK4/6. The reason this is rational is that one of the other key pathways that is activated when you have kind of activation of the signaling pathway leads to activation of CDK4/6, which is very important for helping the cell multiply its DNA and ultimately divide. The cell cannot multiply and divide without actually going through this cell cycle process to replicate its DNA. So if you can block that process, the thought is that, if you're blocking at two different levels, both kind of at the ERK inhibitor level plus at the cell cycle pathway level, that this would be more effective. And, actually our laboratory has shown that in impairing kind of this MAP kinase pathway in combination with CDK4/6 inhibitors was synergistic, was particularly effective in a range of KRAS mutated models, both in cells in the laboratory and also in mouse models. And consequently, that's combining ERK inhibitors, which we, again, as we think would be a more potent strategy with these CDK4/6 inhibitors, we're hopeful will be even more likely to be effective. Palbociclib is the drug that's being studied in combination with the ARA-007 compound. And this is a CDK4/6 inhibitor that is actually currently standardly used in some other cancer types like breast cancer, is being studied in clinical trials in a number of other cancer types as well, typically in combination with other kind of targeted drugs. And so that's one rational combination that we're looking to study. In the BRAF mutated patients, this study will be looking to combine ERK inhibitors with other targeted therapies targeting BRAF. In particular, as we've kind of learned in the last couple of years, the current standard of care for patients with BRAF mutated colorectal cancer is to treat with a combination of drugs called encorafenib, which is a BRAF inhibitor directly in impairing BRAF. And again, kind of talking about this multi-level inhibition strategy, combining it with a drug targeting upstream at the EGFR level called cetuximab. So the combination of encorafenib and cetuximab is currently FDA approved for BRAF V600E mutated colorectal cancer. And this was based on the positive results of a large phase 3 study, the Beacon CRC study, which did kind of represent an important advance in our management of these patients with BRAF mutated cancer. While this was absolutely an important step, we also know that there's more improvement to go. We know from the Beacon CRC study that the response rate among patients was about 20%, which means only about 1 in 5 patients are having a significant shrinkage of their tumors. The remainder of the patients are having stable disease or even growth, despite this being our kind of active combination targeted therapy approach. We know that the median duration of time that patients did not progress through the study was about 4 months, 4.3 months. And the median survival for the patients receiving this combination was 9.3 months. Now, this was actually a significant improvement compared to the prior standard treatment, but I think we all acknowledge that we want to improve on these numbers. There's more we need to do for these patients. And that's motivated kind of new strategies to look at how can we build on this ground to further improve outcomes here. There's been a range of laboratory studies that actually shows that another level of inhibition, hopefully more potent inhibition, would better allay the resistance that can develop when you're treating with just the BRAF inhibitor plus the EGFR antibody. For example, we've seen that you can see emergence of small subclones of mutated cells with other kind of resistance mutations elsewhere in this pathway, which renders resistance to just the encorafenib cetuximab. And as a consequence, there's additional preclinical data showing that adding an ERK inhibitor like ERAS-007 to the BRAF inhibitor and the EGFR antibody may well be more effective in treating or preventing the onset of resistance. And that is motivated, another arm of the study looking at encorafenib cetuximab plus ERAS-007. Now, you may be asking, what do we know about the tolerability and side effects of ERAS-007? So this was a drug that was previously studied in a single agent prior clinical trial. So they looked at just the tolerability of ERAS-007 alone. I will note that in that single arm study, while this was a single drug given, not even a combination, there were some patients with a range of BRAF or other RAS mutated cancers that actually did have significant shrinkage of their tumors. Now, granted, none of the tumors that shrank was known to be colorectal cancer, but I think this does provide an important proof of concept that this ERK inhibitor approach can be quite potent in the right patient with the right kind of mutational profile, further motivating this, the HERKULES-3 study. The side effects from this study were as expected and generally included side effects we would have expected with this class of drugs that we have learned to manage pretty well. And they include things like nausea, diarrhea, rash, and eye side effects, which do require kind of being vigilant for any new changes in vision or other concerning eye side effects. And the study does require ongoing eye exams just for safety through the course of the study. With that being said, these are side effects that are pretty common to this class of MAP kinase inhibitors. And so these are not unexpected per se, and certainly things that we would aim to be able to manage with supportive care. So that's motivated the HERKULES-3 study. So this is a study that has 2 different arms based on the mutational profile of the patients. This study at present is currently enrolling patients only who have either a KRAS or NRAS activating mutation, again, about 45 to 50% of patients, or patients who have a BRAF V600E mutation, about 5 to 10% of patients. Unfortunately, if your cancer does not harbor one of those mutations, at this point, you would not be a candidate for the study, just based on the principle that we're trying to kind of find the best personalized approaches based on the underlying mutational profile. There are other trial options, aside from HERKULES-3 for patients who don't have a mutation in any of these genes. For patients who have a mutation in KRAS or NRAS, as I'd mentioned, they will be studying the combination of the ERK inhibitor ERAS-007 with the CDK4/6 inhibitor palbociclib. For patients who have a BRAF V600E mutation, this study will look at the combination of the ERK inhibitor ERAS-007 with an otherwise standard approach of encorafenib plus cetuximab. It is important to make sure that patients who are interested in this study know what the key eligibility criteria are when at the point in their disease it's really important for you to be evaluated for this study. All clinical trials have particular time points, or kind of they're designed around particular points in a patient's journey with typically stage 4 colorectal cancer, which they should be considered for the study. And if we're not quite at the right point in our journey, the trial would not be the right fit for you. So in particular, the HERKULES-3 study is looking at patients who have had some prior standard chemotherapy regimen. So for the most part, this specific study is not for patients who have had no prior therapy, but usually they will have gotten a standard prior chemotherapy-based regimen. It also requires that they haven't been gotten drugs that are usually given in patients who are more refractory to standard chemotherapies, drugs like regorafenib or tipiracil trifluridine. These are oral drugs that are FDA approved, but are usually given after kind of prior lines of IV-based chemotherapeutic regimens. And so if you've gotten one of those treatments before, this wouldn't be a good fit. So you really should be evaluated for this study before your oncologist is talking about putting you on regorafenib or tipiracil trifluridine. Because if you start that, you won't be eligible for this study anymore. It also requires that patients have not had prior RAS, MEK, or ERK inhibitors. These are not currently standard for patients. So I wouldn't expect you to have gotten this unless you were on a prior clinical trial. And while the criteria are evolving, it's preferred that patients with the BRF-V600E mutation have not previously received encorafenib cetuximab. So ideally, kind of if your oncologist is talking about putting you on that combination, you would kind of quickly get into a center that has the study open to try to get onto this study if you're interested. I think a lot of the patients are probably familiar with clinicaltrials.gov, but you can get more information for this study, look up the sites that are currently enrolling on the study because it's several sites, not just MD Anderson. So you can go to clinicaltrials.gov and type in a keyword like HERKULES-3 or this specific identifier number. This is just kind of the header, but if you scroll down, you'll see more extensive inclusion and exclusion criteria, the sites that are currently enrolling, contact information for the study. So I would encourage anyone who's interested to go to this site for more information. Again, this is a very exciting study. It only recently got underway, so we do think that there are going to be a lot of slots in the upcoming months for patients to go on this study. There are a number of sites that are active and continuing to be activated across the country. So look into kind of where your closest site is. We're always happy to see folks here at MD Anderson, but I'm very excited about the study. I think it's very promising, and I think I'm happy to answer any questions from anyone.
Yeah, Dr. Lee, thank you very much. This was very informative. There are a couple of questions in chat, so maybe we can go through that first. Sure. So this question from Annie is about, prior BRAF and MAPK pathway treatment. Is there, are you okay if people wait for a little bit, or you said ideally you don't want any prior BRAF or?
Yeah, so it's a great question. I think in general, patients try to determine what's the best timing for coming in to be evaluated for a clinical trial. It can be hard because the reality is that logistically, there's always a little bit of lead time that's required to get in a new study, especially if you have to travel and figure out kind of life issues with that. And the reality is if you're kind of actively progressing, sometimes you may be having, patients may have more significant symptoms that are building. What we don't want is for a patient to wait, not get any active therapy before they know it, they've been off of therapy for a couple of months and then start having worsening symptoms or other issues. I'd encourage patients in general, if you're interested in the study, you know that you have a potential activating mutation in one of these key genes to get an opinion at one of the sites that has this study. While you're in the middle of your first line therapy, you may be able to get it kind of with a planned restaging scan. That way you can get plugged in well in advance. You've talked about the study, you have an updated sense of the actual slot availability. Particularly in the earlier phase, the earliest portion of the study, I will tell you, we do have to be a little bit slow and methodical in how we enroll patients, just because we were looking very cautiously for safety of these new combinations. And so we don't want to enroll a ton of patients all at once and then find out there was a significant toxicity and we have to adjust the dose. So there are kind of slots that come and go, particularly in the early phase of the study. So it is helpful to get plugged in and really get an updated sense of, what are the study options, or really other study options other than Hercules-3. While this is a very promising study, there may be other study options that may be right for you. So rather than waiting until you're progressing and then risking a long wait time to try to get into the center, I think it's good to try to get in kind of earlier when you have a little bit more breathing room to figure out what the options are so that when the time comes, you can get in quickly.
Yeah. Okay. So what you're saying is that so is it true that when a person starts, say for example, for FOXITY, and do they have to wait through 8 cycles or till progression to start thinking about this trial, or should they initially itself start thinking about it and get, talking about it?
Well, I encourage patients in general to think about trial options even from the beginning. So if you're very motivated to go for trials, you understand. I always advise all my patients, there's always kinds of downsides, particularly if you're having to travel farther than normal to get on a study. It is important to be aware of logistically what's involved. With all that being said, if you're interested in a trial, I think it always behooves you to get plugged in to a center with a large number of trials earlier in your course. When you're getting standard FOLFOXIRI-based therapy or even a chemotherapy doublet, if that's what you're, whatever standard therapy you're getting, if you're having a really amazing response to therapy, I don't think anyone would tell you to stop what's working. But, and we would hope that that response would last for a long time. But of course, we also understand that at some point that response may run its course, and we want to be prepared and have this plan ready to go at that time. Usually that requires restaging every 2 to 3 months. We typically will do it every 2 months at our center. To keep an eye on things. And so if you already know you're interested in the study, many patients will actually get their restaging scans done with us, for example, so that we are immediately aware of when we need to switch gears.
Yeah, I had a question about the side effects of ERAS-007. You talked about ocular side effects. What particularly are you seeing, or what is known?
Well, these classes of side effects in general can be associated with a retinopathy, which is a retinal, inflammation. Or typically, if you recognize it and you hold the drug, it does get better. And it may manifest as things like blurred vision or flashers or floaters. The study is building in regular eye exams because but you should also be aware and kind of letting us know if you're having any of those side effects. This is a class of side effects that generally we've seen with other kinds of MAP kinase inhibitors, even at other nodes of that pathway. So for example, this is a common side effect we see with MEK inhibitors as well. So it's not unexpected, but it is something we need to be aware of. And of course, when you're giving drugs in new combinations, we have to be aware that there may be a different side effect profile. Again, kind of part of the reason in the early phase of the study, we proceed with due diligence and caution to make sure we're maximizing patient safety.
Okay. So the other question was, you mentioned a couple of doses, right, for thyroid cancer and for the other cancers, 180 milligrams and 250. So what is the dosing? Are you also dose escalating during this initial part of the study?
The initial part of the study does have a dose escalation. Now that's kind of part of the slow and steady kind of slot determination. There is an ultimate dose expansion that's planned, but we are planning a priori for the potential for needing to modulate the doses based on the toxicities we're seeing with the unique novel combinations. So there will be ongoing tweaking of those doses.
Okay. And then about this ERK inhibitor, this is ERK1 and 2 inhibitor combined, right? Blocking both. And how does it compare to, say, the other ones available, like ulixertinib or the BVD drug that you have shown? What is the difference, or how?
So, every drug pharmacologically has different kinds of, affinity for binding for the receptor and different kind of selectivity. Generally, the more selective the drug is for its intended target and the less it hits off target, we would hope for better, toxicity profiles. We do also see differences in the kind of circulating, the pharmacokinetics, which is kind of how long the drug persists, and that not only affects dosing, but the idea is it can affect the optimal effectiveness level of the drug. This is a little bit subjective, but there are folks who will even say that this is more promising. I think you had seen in those preclinical studies, the responses did tend to look better than some of the predecessor the prior ERK inhibitors. So we're very hopeful that this will be even more effective than kind of prior drugs in the class.
Okay, I think there's a question about what information do you have on palbociclib in other cancers? What is the toxicity or efficacy? What have you seen?
Sure. So, we have a pretty good handle on the expected side effects of palbociclib, at least kind of as a single drug. As I mentioned, it is approved with kind of estrogen-directed hormonal therapies in combination in a range of estrogen receptor positive breast cancers. In that context, we typically will see, the biggest potential side effect with palbociclib typically is your blood counts. So it can cause low red blood cells or white blood cells or platelets. So, that's a known side effect we would have to follow. It actually doesn't usually cause too bad of like febrile neutropenia, which is what we usually worry about with, say, chemotherapy and low blood counts. But with that being said, we obviously do have to monitor and be very wary of potential infection and keep an eye on your counts. There can be other side effects like fatigue, like rarely lung toxicity or pneumonitis, rarely, things like mouth sores. These are things we would obviously pay attention to, and obviously the risk in combination would be more potentially there. Palbociclib isn't really given as a single agent, really in any disease type. It hasn't shown much activity. It tends to probably work best in combination when there's another targeted drug that's already partially impairing cell cycle pathways, and then you further hit the cell cycle pathway. So it tends to synergize better with other targeted drugs.
Yeah, I think Annie has another question about like combination of the ERK inhibitor with KRAS G12C inhibitors.
Yeah.
Do you know anything about it?
That would obviously be very exciting. There are a range of trials that are ongoing, obviously, specifically for the G12C patients. If you hypothetically had a KRAS G12C inhibitor, you could go on this study in the KRAS arm. With that being said, there are a wealth of studies that are specifically looking at direct KRAS G12C inhibitors, as we're all aware of. And it's actually, there's an increasing number of compounds and an increasing number of combination approaches. And frankly, that would be a really good option and something that'd be more unique to you if you had a KRAS G12C mutation. So while you certainly could consider the study, and I would consider it, I would also look very hard into KRAS G12C inhibitor-based combinations, because there is a rationale to look at G12C plus other inhibitors of the EGFR MAP kinase pathway that is being studied in colorectal cancer. The exact best strategy remains to be seen, but most of the studies we have, we've enrolled a number of patients on other G12C inhibitor trials, and they're looking at an ever increasing number of potential new combinations to look to see, is there a signal of being more active while remaining tolerable compared to just single agent. So there's a lot more options if you do have a G12C mutation.
Okay, and the other one question here is about EGFR inhibitors. So prior EGFR inhibitors don't affect being on the trial at all, right?
Well, if you have a KRAS or NRAS mutation, you should not have gotten a prior EGFR antibody, so it would be a moot point. For the BRAF arm, it's more relevant about, if you've had prior BRAF in general. I wouldn't expect you should be getting an EGFR antibody alone, but even if you hypothetically did, it will really depend on whether the trial is at that phase of whether it's enrolling kind of patients with prior BRAF and or EGFR antibody therapy or not. But I would say if you have a BRAF mutation, even if you're getting standard of care, it really should be in combination with another targeted agent like BRAF inhibitor.
Okay. And then so the exclusion, or the you prefer to have people who don't have prior BRAF inhibitor exposure, right?
Mm-hmm.
So would there be a go ahead.
The study actually, the reason I phrased it that way is actually different phases of the study. It may allow or may specifically prohibit prior therapy. So generally, it will be safer if you haven't had prior therapy, because at some point the study will reach a phase where if you've had prior therapy, will actually probably be an exclusion criterion for the study.
Okay, so that means that for right now, prior BRAF inhibition is not an exclusion, but it could be later.
Mm-hmm. Yes.
Okay. And then we have one question from a patient. She's currently on folfoxirine plus Avastin, and then she's got a HAI pump and to get to liver resection, and she's asking this would be the best time to think about this trial, right, for her.
I would think about it for sure. I think the biggest question for you specifically is going to be, do you in fact get to the point of a liver resection happening? Because, if you have, what it would mean is that your liver metastases have responded very well and that you're actually, having your shot at surgery. So if you actually do have surgery and have all visible known tumors removed with no evidence of radiographic disease remaining, then frankly, you wouldn't really be a candidate for the study, but that'd be great. So I would think about it just in case it doesn't happen, but obviously the hope would be that you would get to resection.
Okay. How can a BRAF V600 patient decide between Beacon doublet and this trial, and which is more likely to help?
Well, Beacon is your standard of care doublet, right? That's always available to you as a standard of care with your local oncologist. I think, but knowing what we know about, expected response rate, progression-free survival, and wanting to continue to push things forward, improve outcomes, I do think there's an important role for novel therapies, looking at trying to see if, the addition of the ERK inhibitor will build on the Beacon kind of backbone. So ultimately, I think if you're willing to go on a trial and kind of have the logistical bandwidth to go on a study, I would highly encourage you to at least look into it. I think if for other reasons, lifestyle, quality of life, it just doesn't make sense, that's totally understandable. And, the Beacon regimen is going to be totally reasonable to get as your standard of care. And it's honestly the best standard of care approach you could take.
Okay. The next question is about washouts. So if somebody's on chemo, how long do they have to wait till they get on the trial? Is it like the regular 4 weeks or 8 weeks?
I believe it's 3 weeks. Don't let me confirm it. It would be in the clinical trials. I believe it's 3 weeks though.
Okay. So not too much of a wait time.
Yes.
Yeah. Okay. Any other questions? I was kind of, when you showed the figure with the mouse models, you had some wild type animals in there too, right?
In the mouse models, there were wild type as well. Yes.
So it's responding to people who don't have, or the cancers which don't have mutations in the BRAF and KRAS too.
So at least from the mouse data, it did look like that was the case. Now, certainly that'd be a potential future area of investigation, because we obviously know that all patients, with a range of kind of mutation profiles, we want to push things forward and have new trial options. So I think the study was designed with this priority for now, because we know there's a particular need for patients with these mutations. I think I saw a question about what is the known toxicity profile. The study has started enrolling, but it's actually quite early in its course. There haven't been any major unexpected toxicities so far, but this is with a very small handful of patients, and it certainly hasn't been like reported at a meeting or anything, just because it's still so small. I can assure you there are very regular safety calls ongoing to make sure all investigators in the study are staying abreast of any updated safety kind of in real time, which we do standardly for any new combination of drugs, and that's certainly happening with this as well.
Manju, can I jump in? Sorry.
Yeah, sure.
Just, obviously we know something, or like we have some data about CDK4/6 for KRAS patients. Is that, do we have any sort of evidence about what that would do for BRAF patients?
The CDK4/6?
Yeah.
It's a great question. We are increasingly we've been looking at CDK4/6 in a range of mouse models actually. And, while there certainly is kind of some promising preclinical data, I think it certainly would be another realm of investigation for us to want to look into. There are a lot of really promising BRAF trials right now, actually, that are trying to build on Beacon. So really the question has been a matter of like, what is like the most promising way to go? So, CDK4/6, certainly there's a lot of interest in it. I will tell you at our center, my colleague Van Morris, who I'm sure you're all very familiar with, has probably talked to you about some of their emerging data about kind of the Beacon regimen plus immune checkpoint inhibitor therapy, and he'll actually be discussing those outcomes at the upcoming GI ASCO meeting.
Oh, good.
With the early data, and there's ongoing discussions about that becoming a larger, kind of much larger study. So I think we're very excited about that data in particular for BRAF patients. Yeah.
Okay. And I'm again going back to the mouse data. So you had the HCT119 cell line, right? In that figure. So is that like a subcutaneous model, or have you checked in like a PDX model or something, or?
So it's looked both at kind of traditional cell line models, right? But on the right side of that figure was actually a range of colorectal PDXs, specifically patient-derived xenografts. So it was looking both at kind of traditional cell line models plus PDXs.
Okay, that's good to know. What else? This is very useful. Thank you so much for your time. And we'll probably give like 1 or 2 minutes if anybody has any other questions, and then.
I think someone had asked about efficacy even in the last few months. I wish I could tell you something more concrete, but right now it's still extremely early in the course of the study. We're still even kind of at a point of getting dosing. As we said, we're firming up the dosing and the tolerability. So it's very hard to say right now anything broadly with just a handful of patients.
Mm-hmm.
Can I ask one, Manju? That dosing question is really important. I mean, so I was on the Beacon doublet arm, on the trial arm like 4 years ago, and then over the past year, I did it again with ulixertinib through their expanded access program, and like I ended up getting 8 months. Like I got twice as long on this combo with the ERK
Wow.
as I did with I got 4 months on the trial, even though I'm much farther out. But it was a real challenge to try to juggle those doses, because we really didn't know how much, and it was, I had a lot of toxicities related to it. So yeah, I don't really have a question. That's just sort of more of an N of one example of that. It was really to figure out what the right dosage was going to be.
And I think that's really important, because exactly as we're getting at, I will say that targeted therapies, some patients think, oh, targeted therapies are not going to have any side effects like cytotoxic chemotherapy. And that's of course not the case. It's a different side effect profile, right? It's more like not like the really bad toxicity that gets better. It's more like we have to learn how to live with these toxicities over a long time. So like a moderate toxicity that just never goes away is quite bothersome as well, and perhaps arguably more so than a more significant toxicity that goes away in a couple of days, right? And so, part of the study is looking very carefully at what is the best dosing schedule, along with dosing. That's all kind of being pre-specified and still, active discussion. And that's kind of a key point of the early phase of the study. So we know what is the best strategy to go to before we kind of go into a larger expansion phase where the slots aren't going to be so limited, but we'll have a better handle so that, all the clinicians, the investigators on the study have a better sense instead of feeling like they're having to go it alone to figure out the dosing, right? Which may have been your N of one experience.
Yeah, I think John has a question. He's asking, do you have a sense of how quickly you expect to see results or not? So are you going to have like interim results when you have the safety part done before you go into a dose expansion?
Yes and no. I mean, so of course, there will be ongoing evaluation of the results, but it's always very tricky when you have only like a handful of patients to make a firm conclusion about the efficacy of the study. Even the Beacon regimen, which as we all recognize, was a major advance, had a response rate about 20%. So hypothetic, I mean, I know actually the earlier patients actually had a really high response rate, but hypothetically, if you'd had a treatment that had a 1 in 5 response rate and your first 5 patients just, you didn't happen to see anyone have a response, you might prematurely say, oh, that's not active, and that wouldn't really be accurate. So you do have to be really careful about that. We obviously do want to get the results as quickly as we can, but we also want to recognize that, not every, we need to get a large enough sample to know really what the true efficacy is.
Yeah, okay. I have a question. So in Dr. Corcoran's trial where he had the spartalizumab with the MEK inhibitor and the BRAF inhibitor, he was using ctDNA to see, whether the BRAF levels go down, and that would be an early indicator of efficacy, right? Are you planning to do something like that? What exploratory endpoints are you looking at?
Sure. I mean, there are a range of, any early phase study has a lot of endpoint, like additional correlative studies. A lot of them are pharmacokinetic studies where they're really looking to see what is the dosing level attained by the drug, and like what is the level of the drug in your body at that time point. So that's standard. It's pretty cumbersome, honestly, for the patient to have, but that's standard. ctDNA is built into practically every study at this point. I will tell you, it's probably not like an immediate readout or necessarily going to be used to determine if it's working or not, continue or stop. From that perspective, we'll still be using the tried and true kind of radiographic imaging based endpoints. But pharmacodynamics and pharmacokinetics are a key point of what happens in these early studies. Patients, we're very grateful that patients are so willing to kind of take those steps. We can truly know, was the drug working? Was it doing what we intended it to do? Because we really need patients to be willing to get extra blood draws or even biopsies and things as needed. So we're very thankful for patients to be willing to do that.
Okay, thank you for that. Yeah. I think this has been, I think we covered all the questions, and this has been very useful. So what I'll do is that I'll have the video available in COLONTOWN University as well as COLONTOWN. And if you want, if you're interested in having your patients watch it, or somebody who's interested in the trial watching it, I'll be happy to share a link so that you can have them watch it.
Yeah, that'd be great. Thank you so much.
Yeah. Okay. Thank you very much for your time.
Thank you, everyone.
Yeah, thank you.
Yeah. Take care. Bye.